Yeah. So happy to be again with the team White Army. Last time we had a good interaction and one of the residents presented case. This time I thought of demonstrating how to examine abdomen. So I'll go ahead with the video. So I'm just introducing myself there. With regard to clinical examination, we should always make sure the ambience should be always fine. Before getting into examination proper, explain the patient about the procedure you're doing, whether the procedure involves any painful act, any distress, or whether it causes any discomfort to the patient, how long does the procedure last, and what is the advantage of examining him. This is very important because you see in different clinical setting, the examination duration totally varies. Sometimes we spend just 10 to 15 minutes with the patient. Sometimes 30 minutes is required, 40 minutes, and sometimes even beyond that. There is no limit for clinical examination. But from the patient perspective, we should always give him everything in prayer. He should not feel that, what is this? Doctor is examining me from 20 minutes, 30 minutes. What is he doing? If you don't explain all these things properly, by the end of, let us say, 10-15 minutes, patients get fed up and they may not cooperate. So it is always better, give them a rough duration. Let us say, dear so and so, I will be examining you for next 15 minutes. I will be examining you for next 20 minutes. This examination is essential and it's a part to arrive at good clinical diagnosis. This examination will not hurt you generally. It will not distress. If at all, if there is any distress, any pain or anything, please let me know. So this is what you should explain your patients, take their consent, and then you should go ahead. So here you can see I'm just I'm just explaining him. This will help you to gain the confidence of patient. So after detailed examination, it's very important you check. So about the ambience there, the room should be well lit. Even if you don't have windows, it should be bright. It should have a good lighting system, and patient should have good privacy. So after explaining everything, suppose if you have a female patient, please make sure that you have a female attendant with you. Preferably, you should have a hospital staff, like a nursing staff or anything. Preferably, a hospital staff, female attendant should be there. So this is how a patient, lies there. There are, see, this is one important thing which you should find. Always patient should be at rest, lying straight. The arm should be on either side. There are few who says arm should be just beneath the head or it should be folded upwards. Please don't do that. When you fold arm, or when the patient keeps his arm beneath the head, there is undue stretch in the upper part of abdomen, which will interfere with your examination. So you have to flex his knee and thighs a little bit. There are a lot of discussion in the undergraduate days about the angle which it should be bent. Some say it is 30 degree, 45 degree. Some say it is less than 30 degree. Please don't go dig too much into that. 30 degree, 45 degree definitely will not make any difference clinically. Just let the patient be comfortable, flex his knees and thighs. This maneuver is to relax the abdominal wall muscles. Some individuals, let us say elderly, somebody who is 50, 55, 60, and if you are planning to examine them for next 10 to 15 minutes, they may not feel comfortable in holding the flexed knee and the flexed thigh position. In such cases, you can keep a pillow, you can keep two pillows just below their knees to make them comfortable. See, this is one of the maneuver, when they can't hold that flex knees and flex thighs, just place a pillow beneath the knees so that they'll feel comfortable. Of course, here is a young boy who can just maintain the position. So I just remove the pillow there. Make sure that, since abdominal examination also involves examination of external genitalia, inguinal region, pubic region, make sure that you cover them with a blanket, and it also gives a sense of warmthness to the patient. See, am I exposing now? With his permission, I went ahead. So I'm exposing the abdomen from the nipple to the inguinal region or thigh. Most of the patients will not feel comfortable when you directly ask them to just, okay, I'll examine your external genitalia and all those things. It is better we complete our examination of abdomen first. Then that will gain confidence, and then you can go with the external genitalia or exposure up to the thigh. So in a flexed position, we'll begin with inspection first. Inspection is done in two ways. Here you see I am standing on the foot end of the patient, inspecting the abdomen. Then I come to the right side of the patient and see abdomen from the lateral end, that's the lateral view. Suppose we know majority of us are right-handed individuals, so we prefer to stay on the right hand side of the patient and examine. If at all, if somebody is a lefty and they want to examine, please inform the examiners prior that I am left-handed, so I would like to stand to the left side of the patient. Okay? You need to explain to the examiner and then proceed for that. In this video, I was just briefing about how to go ahead with the inspection. There are two ways I told you. What to see in inspection actually. Please make sure that you initially assess the abdomen as a whole. So how is the abdomen looking? Is abdomen normal or it is scaphoid? In adults, we do see in a lot of end stage cancer disease patients who are cachexic. You see that scaphoid abdomen, or it is distended. If at all distended, whether it is uniformly distended or is there any regional variation? When you describe abdomen, the other day I was discussing that abdomen is divided into 9 regions and 4 quadrants. 9 region, we have 2 vertical lines in the MCL, 2 horizontal lines. One is a transtubercular and as well as transpyloric planes or transpyloric lines, which divide the abdomen into 9 regions. Please don't use the word quadrants. Quadrants means it is 4. Definitely, there is a lot of description, a lot of clinical entities we do in quadrant wise. We say right upper quadrant, left upper quadrant. Quadrant means abdomen is arbitrarily divided into 4 things. So here I'm describing the planes here, trans tubercular and trans pyloric planes. Please don't get confused between regions and quadrants. Quadrants is always 4, where grossly we say there's something in the right upper quadrant, left upper quadrant, right lower quadrant, and left lower quadrant. There are only 4 quadrants. So in the inspection, please go ahead and describe in region or quadrant terms. The first thing which you'd like to describe is the shape of the abdomen. In the shape of the abdomen, if at all, if there is a change in shape, if there is a distension, you're going to mention whether it's uniform distension with or without flanks full. Whether there is a regional distension, you're going to mention, like abdomen is distended more in the upper part, abdomen is distended more in the lower part, or the right upper quadrant shows distension. Suppose if you see a swelling, you're going to describe the swelling. Preferably, swellings are described on region basis. Epigastric region shows a swelling. The periumbilical region shows a swelling. The right upper quadrant. Suppose you are not able to make out the regions, you can just say right upper quadrant swelling. But preferably, swellings are described region wise. So once you describe swelling, you all know, let us say you're describing a epigastric swelling. You say there is a swelling in the epigastric region measuring dash into dash centimeters, xyz centimeters, with ill-defined or well-defined margins, whether it moves with the respiration or not, whether it is pulsating or not, all those things. If there is no swelling in the normal abdomen itself, can you see any swelling, any pulsations, any peristalsis? Everything should be mentioned in inspection. Suppose you see any visible peristalsis, you have to mention. Let us say, next important thing which you should describe is a skin over the abdomen. How is the skin over the abdomen? Whether the skin is fine, normal skin. Do you find any scars? How are the hernial sites looking? Any surgical scars or any other things? Describe them in detail first. Then go ahead with if there are any visible veins, which is very important. Most of your abdomen case has this entity, veins. Visible veins are different. Engorged veins or enlarged veins are quite different. Particularly in a fair individuals, in a thin individual, you may see little visible veins, but visible veins are not pathological. They may be normal. If at all, if they are engorged, if they are enlarged, if they are tortuous, you need to describe the direction of flow. We all know that umbilicus acts as a watershed area. The direction above is towards the head end, direction below is towards the foot end. So this is the watershed area I'm describing. Once veins are engorged, you need to make sure that what is the direction of flow. Empty the vein with the 2 fingers, as I'm doing here. Then lift the caudal finger, check for the direction of flow. You can lift the upper finger or the cranial end and to check the direction of flow. Again, empty, lift your upper finger and to check the direction of flow. This is how you examine the veins of anterior abdominal wall. We all know that other than anterior abdominal wall, in cases of hepatic venous outflow tract obstruction, in other words, Budd-Chiari syndrome, other than the anterior abdominal wall veins, we also see veins in the flanks and as well as in the back. So how do you examine them? So veins in the flanks and back to be examined like this. You can see here, patient should be made to bend forward with his hands hanging down or hanging sideways. Patient stands and bends like this. Then you should see, you should observe the veins over the lateral abdominal wall, flanks or at the back. This is very, very important because presence of veins in the flanks or at the back definitely points us towards a different diagnosis because the level of obstruction differs. So make sure that if you find one or two veins in the flank or back, please ask the patient to sit, stand, bend forwards, and then look for veins over the flank. Particularly this, you suspect this whenever patient has a sudden onset of ascites or painful ascites and you are suspecting Budd-Chiari syndrome or hepatic venous outflow tract obstruction or IVC obstruction. It's very important. So somebody with a painful ascites, please check for all these things. After that, just note down how examination, how abdomen moves and everything. Here I'm describing little skin changes in the abdomen. Skin changes other than scars and visible veins. You look for some signs, particularly the discoloration around the flanks, discoloration around the umbilicus, and somewhere around the inguinal ligament. Discoloration around the flanks, which is known as great Turner sign, around the umbilicus, which is known as Cullen sign, and Fox sign, which is around the inguinal ligament, which is usually seen in hemorrhagic pancreatitis, ruptured ectopic, etc. Often these patients are seen in emergencies. You should see them in emergencies because normally you don't get these patients for a clinical examination in examining. So just at least for theoretical sake, you should know what to look. Then over the flanks, you see for striae. Striae, commonly you see striae in obese individuals when there is a rapid expand or anything which causes rapid expansion of the anterior abdominal wall. Most commonly, you might have noticed, a lot of obese individuals have striae. And pregnancy also causes a lot of striae. And people on steroids, we give steroids to a lot of conditions in GI disorders. So people who are on steroids tend to have striae, but steroid induced striae, the color will be a little bit different. It is usually reddish, purplish, or the plum hue colored striae you see when it is a steroid induced. But in case of obesity or a post-pregnant state, these striae will be light white in color. So you look for all those things, particularly in the lower abdomen, below the umbilicus. So all skin changes, abdomen as a whole, to be described in detail. You make sure that write a diagram in your case sheet. That's very, very important. Both for if you find some inspectory findings, anything, anything important in the inspection, please mention in a case sheet. Draw a rough picture of abdomen. Make sure you mention whatever, if at all, if there are some dilated veins, scars, anything. Just draw a rough diagram. It'll be very helpful for you and it fetches marks. Suppose even in future, if you don't, in the examination while presenting cases, if you forget something, but still if you have mentioned in your diagrams, definitely examiner is going to recognize and give marks. You don't have to, sometimes out of stress or something, you may not tell all features, but still definitely examiner appreciates you. So please write diagram, just draw an abdomen diagram and mention the important inspectory findings. A lot of things are described about umbilicus. If umbilicus is fine, just write it's normal umbilicus. But if the abdomen is distended and it is stretched, you have to describe it that it is stretched horizontally. The distance between umbilicus, spino-umbilical line, and all those things, as I mentioned in my previous class, is more important when you have non-uniform distension of abdomen, when there is a preferential quadrants or regions are involved, particularly in ovarian tumors and any tumors or swellings involving the adnexa. Otherwise, it carries a less value. If it is uniform distended and you measure that the spino-umbilical distance, umbilico, that distance, it's all same. So there's no point in dragging too much over those things. So don't waste time in those. So after clear-cut inspection, we should go ahead with palpation. Never ever mention in the palpation that do not skip any methods in palpation. That's what I meant to say. Do not skip any methods. Because I've seen some people telling, have done this in inspection, have written this in inspection, then why should I go ahead with palpation? No, it's written clearly in inspection. No. So here I'm describing, before getting into palpation, all of us should know what are the normal abdominal organs which are palpable. They may not be pathological, but still, while palpating, we encounter these things. So we may get confused, whether there's a problem, is there some problem, or it is just a physiological entity. So coming to normal palpable organs are, one is liver. You should remember this, that a palpable liver is not always pathological. Just palpable liver or a palpable liver sometimes may not be pathological. So palpable, you can palpate liver in, the liver may be just palpable in a healthy individual. One. Two, in a very thin individual, you can see in the midline the aortic pulsation, or even if you try to palpate, you can palpate the aortic pulsations. So aortic pulsations in thin individual is a normal entity. In people with good recti tense, the abdominal, anterior abdominal muscles, rectus abdominis, if it is good taut and tense, even you can palpate the rectus abdominis muscle. This is very, very important. Clinically, you should feel this, because most often when you proceed for examination of spleen from the right end to the left, so you encounter this border of rectus abdominis muscle, and you feel that no, this is spleen, this is some organ, this is something which is palpable. You should make sure that It is not rectus abdominis muscle. So rectus abdominis is something which is, the lateral border of rectus abdominis. Usually, it is clear cut palpable, appears as an edge of, let us say, border or edge of any palpable organ. Another entity is palpating small lymph nodes in children or somebody who is, when they're less than 14 years or something. Adults, you may not get, of course, adults, if they have some infections, you may get it. But normally in children, you may find small lymph nodes in the inguinal region, which may not have any clinical significance. Another entity is palpable fecal matter, which is often seen in elderly patients. Elderly patients who are bedridden or who are confined to bed for many days, who suffer from constipation, sometimes comes to OPD. And when you start palpating their, let us say, the left flank or anything, you feel some mass like thing on the left end. The first conclusion, if somebody sees a mass like thing in an elderly patient who is constipated, is something mass. Is there any mass in the abdomen? And most often it's mobile, and once they pass stool with enema and everything vanishes. So sometimes hard stools in elderly, they are palpable. So revising, so normal palpable things may include just palpable liver, the lower border of liver, one. Gallbladder, just tip of the gallbladder may be palpable. The lateral border of rectus abdominis, small lymph nodes, particularly in the inguinal region, may be palpable. Abdominal aortic pulsations may be palpated clearly, and solid fecal matter can be palpated in elderly. So after knowing the common things, let's go ahead with examination. Please rub your palm. In this part of the world, it may be a warmer temperature. We may not rub our hand, but always in colder environment, should rub your palm. Before going into the palpation, just you should have a superficial palpation. When it comes to, there are two entities here, superficial and deep palpation. The superficial palpation becomes more significant in surgical cases, because you want to rule out some parietal, you are examining a parietal swelling, or you are examining something where patient presented to you with pain abdomen. You want to see whether it is involving the both the layers of the peritoneum. You want to look for any rebound tenderness. You want to look for any rigidity. Then it becomes more significant, when you present a swelling or pain abdomen or acute abdomen or something like that. So we'll go ahead with palpation of liver. I've explained the patient, and again I'm going to reinforce it, because the moment I keep my hand there, you should not make his abdomen tense. The tips of our fingers are more sensitive, but that doesn't mean that you have to poke abdomen with your tips. Please use your palm, flatten your hand, start from the lower end, look at the borders of liver here, parallel to the lower border of liver. I'm going slowly, just move by 2 centimeter slowly. You should always wait for one complete respiratory cycle. If you place your arm, if you place your palm, just wait till the patient takes inspiration, expiration, inspiration. Don't poke like this. This is what people do. They just poke and go ahead. No, don't rush. Place your palm, wait for complete one respiratory cycle. Let the patient take deep inspiration, and if at all, if the organ is enlarged, it descends. You can see here how I'm showing the direction. It descends with the height of inspiration. by roughly 1 to 3 centimeters. And if it is enlarged enough, definitely it touches your fingertip. It slips if it is enlarged. So that is the area where you feel the organ there. You may ask the patient to again take deep breath, go slow always. Don't poke abdomen, because we all know that in examinations, almost patient will be exposed to too many students. Your prior friends would have been would have examined him in different positions. And again, after all those things, you go back and examine the same thing, patient may feel bad. But if you keep talking to him, that is one big advantage. If you keep talking to him, somehow engage him, then go ahead with examination. Make sure that you place, see, this is the wrong method. Make sure that you should place your left hand near the patient's shoulder. That gives a confidence. Keeping your hand in this position and examining liver is not suggested. What you should do, you should keep your hand like this over the right shoulder, you see, then go slowly. That is how you go. Sometimes people check like this, they poke their fingers and check whether is it liver or is it something else. Please do not do that in front of examiners. You should be as gentle and slow as possible. Once you feel the palpating end, make sure what is the edge, how is the edge of the palpating liver, how is it, whether it is sharp, whether it is round, whether it is irregular. Next thing is the surface. Unless the organ is enlarged to that particular extent where you can feel the surface, please describe the surface. If at all, if the organ is not enlarged to that extent, please mention that, sir, I'm able to feel only the edges or border. The border appears to be irregular. I'm not able to feel the surface because liver is just palpable. I'm not able to feel the surface properly. It's okay. It's okay that if you just, if the, at the height of inspiration, if the liver is coming and just touching your hands, it is difficult to appreciate the surface. It is smooth surface and all those things. Of course, consistency can be appreciated even if the borders are palpable. So, if the organ is enlarged enough, let us say you have a 4 centimeter liver, you have a 6 centimeter liver below the costal margins, then you are bound to describe the borders, the surface, the consistency, whether there is tenderness or not. If at all, if there is a tender, make sure that if it is too tender, don't keep poking just to know the surface and all those things. If it is tender, you can tell the examiners that, sir, organs, let us say there is a hepatomegaly 6 centimeter below the right costal margin. It is tender. It is tender on palpation. We all know that tenderness is due to inflammation. And anyway, examiner will not expect you to do repeated things to know the surface and everything. So this is another method of palpating liver. You can see here, I have placed my left hand below the right flank, between, you can see between the 12th rib and the iliac bone. I have placed my left hand and I am palpating liver through the other hand. This is known as bimanual method of examining liver. So when do we do this method? When do we go ahead with bimanual examination? Bimanual examination is advised in patients, let us say, who are obese. It is difficult for you to grasp the liver. Somebody with 100 plus weight with a fatty liver comes to you, 19 centimeter liver comes to you. It's very difficult, to appreciate the liver. So you may try bimanual palpation. Or if somebody who is muscular, a bodybuilder comes to you, then you may be difficult because you may just palpate the muscle borders there. So in those cases, let us say if the patient is obese or if he has a muscular body where it is difficult to appreciate, please put your hand, don't put the left hand below the rib cage. It doesn't make any sense. Just come below, just below the 12th rib, place your hand, lift it upwards, and then go ahead with this bimanual palpation of liver. You will better appreciate these things. So this is another entity, how to examine liver. This is another method where you parallelly place your fingers pointing towards patient's head and slowly proceed upwards. Slowly proceed upwards. Wait at the pause at the height of inspiration just to feel the liver border. There are some examiners or some people who say you should come from above downwards with this method. Just I'll repeat the thing. Don't come from above downwards, because if at all, if the liver is enlarged, if you want to find the lower border, it is easy by conventional method itself. You're trying this two-hand method. Just a minute. Just give me a minute. Let the video. Yeah. Yeah. This method, you should go preferably from the lower end upwards, so that at the height of inspiration, the liver border touches you. You don't do this method normally. Normally, if you're palpating, let us say the liver is 6 centimeters, 8 centimeters beneath the costal margin, and well palpable in the normal conventional method, there's no need for this maneuver. You do this maneuver when there is, let us say, only the tip is palpable, difficult to appreciate, and all those things. You do this maneuver. Really, you will appreciate. Let us say the liver is just 1.5 centimeter, 1 centimeter, just touching at the height of inspiration. You will appreciate this. Another method of examining liver is hooking method. Remember, hooking method is not done when there is obvious huge hepatomegaly. You have a 20 centimeter liver, you have a 18 centimeter liver, please do not do hooking method. Hooking method is done when you want to palpate the liver edge and when there is no obvious enlargement. You want to palpate the liver edge, but there is no obvious enlargement. You just want to palpate it at the height of inspiration. Then do hooking method. If there is obvious hepatomegaly, a large fatty liver secondary to alcohol or anything, any storage disorders or anything, then there's no point in doing hooking method. Do not do, just because you want to demonstrate all the signs for hepatomegaly, don't go ahead and examining everything. If a conventional method shows good palpable liver or good enlarged liver where you can appreciate the borders, where you can appreciate the surface, the consistency, everything, then there is no point in doing a bimanual also, then the other method also, then the hooking method also. It's not required. So this we do only when you want to appreciate the border or tip of the liver. We all know that hepatomegaly and palpable liver are different entities. Make sure that when you are When your liver is just palpable, describe it as palpable liver. What common mistake we do is we just say, sir, there is hepatomegaly. I can feel it. Hepatomegaly 1 centimeter below the costal margin. There is hepatomegaly 2 centimeter below the costal margin. No, unless you determine the liver span, do not commit hepatomegaly. It may be just palpable liver. We all know that there are various conditions where liver is just pushed downwards. The liver span may be normal, but it is just pushed downwards. For example, you have emphysema. An inflated lung pushes liver down. Let us say an effusion, large effusion on the right side, it pushes liver down. In long distance runners, diaphragm extrusion, it pushes liver down. The liver size may be normal. That's why whenever at the end of palpation, definitely their examiners will ask you, what is your findings at the end of examination? You say, sir, there is hepatomegaly. No, at the end of palpation, it is difficult to say whether there is hepatomegaly or not. You can just say, sir, the liver is palpable. After determining the size, like you perform percussion, you determine the span, then you can definitely commit, yes, sir, there is hepatomegaly of 18 centimeters. There is hepatomegaly 20 centimeters. So till then, just at the end of examination, please don't commit, because a lot of examiners, they say just examine liver. They'll tell you the moment you go near patient, you examine that, sir, there is hepatomegaly. No, you can commit that for spleen, but not for liver. So here I am showing how spleen enlarges. We all know that spleen, to be palpable, it usually doubles its size. Clinically, previously we used to follow Hackett's method of determining the extent of splenomegaly. If the spleen is hiding beneath the ribs, it's grade 0. If it is just touching the ribs, next grade. If it is somewhere between the costal margin, and umbilicus, we give a different grade. And if it is crossing the more than the 50% of it, is a different grade. If it is reaching umbilicus, a different grade. Some books gives 4 grading, some book gives 5 grading, some include 0, some don't include 0. Anyway, that's fine. And there is another method of telling spleen, and liver both. Instead of telling it in the centimeters, some say it is finger breadths. Liver is enlarged 3 finger breadth below the costal margin. And sometimes even the spleen, it's determined 1 to 3 centimeters, 3 to 5, 5 to 7, or 1 to 3, 3 to 7, and beyond 7, like that. There are different classification. However, if it is up to umbilicus and beyond, definitely you can see how we start for the spleen palpation. We all know the direction of enlargement. We go from the right side diagonally, slowly, again slowly, with each respiratory cycle. Don't go with each breath. It is not that inspiration, expiration, inspiration, expiration. No, you don't do run 4 steps ahead with inspiration, expiration. No, what you should do is just place your palm, let the patient expire, take deep inspiration, then expire. So this is one complete respiratory cycle. Then slowly move diagonally towards the left upper quadrant. Suppose if you're not able to appreciate splenomegaly, then we place the patient into right lateral position. Clinically, I can say this is the best method to examine spleen. Just again go from the same thing, same direction, diagonally. Slowly go ahead, go ahead. If at all spleen is palpable here, notch, feeling the notch. If the spleen is just palpable, or if you are able to appreciate only the tip during the height of inspiration, it is difficult to appreciate. Suppose if you're difficult to appreciate, it is better to commit that, sir, I can feel the spleen, but I am not able to appreciate the notches. In case of massive splenomegaly, if the spleen is too much enlarged, definitely you should appreciate the notches. Otherwise, clinically it is difficult to appreciate. Sometimes what happens if it is a just palpable spleen, spleen is hiding beneath the costal margins, and examiner asks you to, okay, let me know whether the spleen is enlarged or not. Here you can commit, yes sir, there is a splenomegaly because I can feel the tip, but I'm not able to appreciate the notches. It's fine, you commit. I've seen so many students, just they feel the tip of the spleen and they start describing, sir, I can feel the notch, I can feel that, this. Please don't go ahead with all those things. If you're not able to appreciate, fine. This is another hooking method for spleen. It's just same as liver, nothing new. If the margins are hiding, the Hackett's initial grading, where the margins, the enlarged margins are hiding beneath the costa, the ribs, you can do it through hooking method. There is another fancy method which was mentioned in most of the older clinical method, some broken bow phenomena, where you make the patient to jump in the ward and then make sure that it descends a bit by 1.5 to 2 centimeter. Then you can appreciate both liver and spleen better. Nobody practices that method. I think the current clinical teaching everywhere in the world, nobody practices that method. Just know it for theoretical sake. If some examiners, older examiners, if they ask, if you're not appreciating, then what do you do? Then you may tell the patient, maybe we'll make the patient to jump few times, then go ahead. But nowhere it's done. But just know the theory, don't do it. Suppose if you don't get the spleen, you tell, sir, I tried in this way, I want to confirm it through percussion, instead of making the patient to jump and again examine, do all those things. So this is about the palpation. Then we'll go to percussion. Palpation in abdomen is very important because there are obvious things here. It is not like you feel, it's not like something other subjects, you feel something, examiner may not feel. It is difficult. If you feel the tip of the spleen, everybody should feel the tip of the spleen. It's not like you appreciate murmur, your colleagues will not, your senior will appreciate, nothing like that. If abdomen, in case of abdomen, if you feel spleen, everybody should feel spleen. If somebody is feeling and you're not feeling, either like one of you may be wrong. So abdomen examination should be accurate. And advantage of all this abdomen examination is, clinically it becomes very, very, very important, because the first set of investigations for any abdominal uh, pathology or any abdominal illness would be an ultrasound. If a good ultrasound, if you get, definitely they'll add some important entities. If not, majority of your ultrasound features are nothing but your good palpation results or good clinical examination results. If you're able to feel the liver, if you're able to feel the spleen, measure everything, report, this will be your ultrasound report. Patient has hepatomegaly, liver measures this thing, you're able to palpate the spleen, this. So clinical examination is very important. We'll go ahead with percussion. Percussion is broadly divided in abdominal examination into three entities. The first thing would be a solid organ percussion, whether they are pathological or normal. First, we go ahead with solid organ percussion. Then you want to look for free fluid in the abdomen. To look for free fluid in the abdomen. Then you go ahead with percussion of other areas if required, based on the case. In the solid organ percussion, we start with the liver. You see in the mid-clavicular line, I've started percussing from the third space in the mid-clavicular line. I'm going caudally. Suppose if there is a change in your percussion note, Do not hesitate to go back and check. You want to check twice, thrice, please go ahead. But appreciate the change in the note, how it changes from air in the lungs to a solid organ in liver to a tubular hollow organ, how it changes. Just make note of where exactly the percussion note changes, measure it with a tape. That gives you liver span. There are Indians have less liver span when compared to others. In India, it is roughly around 9 to 12 centimeter. The liver span largely varies according to your height and build. In India, it is roughly around 9 to 12 centimeters. You have a published paper from PG Chandigarh. That's a good study. That's the only and good study. The Indian liver span is roughly around 9 to 12. Of course, in the Western textbook mentioned somewhere between 12 to 14 centimeters. That's fine. Indians somewhere have 9 to 12 centimeters. There are two entities here. So what happens if there is ascites? If the abdomen is full of fluid, if there is ascites, the dullness of lower border of liver in that case is continuous with the fluid dullness. So here you have to combine. You are still see the examiner will ask what happened to the lower border. Then you can just say, sir, the lower border of liver is in continuous with the dullness of free fluid in the abdomen. Then how do you measure liver span in this? Suppose if the liver is palpable either by the conventional method or dipping method. Dipping method is not a different entity. Same conventional method, you give a sudden press to displace fluid. Do not do dipping method in normal individuals or a thin individuals like him, because it is really uncomfortable and they may feel pain. So dipping method, you should, that's why I didn't demonstrate even in this patient. Suddenly dipping method definitely will elicit pain or it is uncomfortable. So by dipping method, you can find the lower border of liver, just have an arbitrary marking. You can get the upper border of liver through this percussion, then measure the liver span. Sometimes, massive ascites also leads to right-sided pleural effusion. When there is a large effusion on right side, it may be still difficult to appreciate the upper border of liver. If it is a small effusion with the posture, let us say you make the patient sit and percuss the upper border of liver. This is feasible only when a patient has small or minimal pleural effusion. If the pleural effusion is large, when there is a right-sided massive pleural effusion, it is difficult to appreciate the upper border of liver. In that case, you can definitely tell your examiner, sir, I'm not able to appreciate the upper border of liver because of massive effusion on the right side. So this is about liver percussion, finding out the liver span. And after that, we go ahead with percussion of spleen. Here, you need to describe this under three separate headings. One is percussion of prob space, then other two methods of percussion for spleen. Let's just wait for a minute. We'll go ahead. I'll show you how to demarcate or know the top space. So this is, I'm just demonstrating. So how to measure case of ascites, you have to take a liver span. Just use dipping method, find the lower border, find the upper border by percussion, measure, and you get a liver span. So here I'm just showing the borders of drop space. I'm counting there. We all know this line you can see here. It is the sixth space, sixth rib margin. It's a triangular or semilunar space. It has three borders. One is the anterior axillary line, then the lower costal margin, and the sixth space. That space you need to percuss. That is drop space percussion. We all know that drop space is a semi-lunar, or I can say roughly a triangular space bounded by the sixth rib, lower costal margin, and anterior axillary line, which is occupied by the fundus of the stomach. Since it is occupied by the fundus, it is tympanic. Drop space is tympanic. When it gets obliterated, we know there are various causes where drop space get obliterated. But in case of abdomen, when you are examining abdominal causes include enlargement of left lobe of liver, splenomegaly, or a tumor involving the stomach. So in all these cases, you feel that drop space is obliterated. It just shifts its note from the tympanic note of stomach to dullness. So this is the area which I'm just showing. So next entity is Castelli's method and Nixon's method for percussion of spleen. So this is the costal margin. You can see I'm just delineating it. This is the costal margin. Midway in the costal margin, I draw a perpendicular line. It is a perpendicular line in the costal margin. So in the midway, I just draw a perpendicular line. I'll show you again. See, this is the costal margin. I'm placing my pen perpendicular to it, 90 degree. You see it's a diagonal line moving upwards. I'm percussing along that border. This is a Nixon's method. You should measure the length of dullness here. If the length of dullness is exceeding 8 centimeters, then there is a splenomegaly. Another entity, now what I'm showing is Castelli's method. See, I'm counting the ribs, the spaces on the anterior axillary line where it ends. We all know that it roughly ends in 8th and 9th space. See, that's where it's ending. I'm pointing it there. See, I'm again counting, and anterior axillary line ends there. That's the space. Just focus on that space. If it is dull, then there is a splenomegaly. There is chances of splenomegaly. So, and along the anterior axillary line, we often get confused, what is Castelli's method, what is Nixon's method. So how I usually teach is, we all know Castelli's is CAS. A is anterior axillary line. Okay, percussion along the anterior axillary line at the end, particularly in the 8th or 9th space. If it is dull, it is due to splenomegaly. That is Castelli's method. Nixon's, you know how the letter N is. N is something zigzag, no? So that is angulated. So Nixon's requires some angle, that is that's what I'm showing here. The lower costal margin, perpendicular line to that, measure the length of dullness, and if it is exceeding, that shows splenomegaly. So very important, sometimes we may not appreciate a just palpable spleen. This often happens in our day-to-day clinical practice, particularly in exams, where you're tensed and you keep poking your this thing on the right lateral position. You may not feel the spleen, and suddenly examiner comes and asks, repeat the examination, just go and check the spleen. This is one tricky area where people want to just confuse you. Here you should be confident after doing percussion. Please do this percussion method. We all know how the spleen is there in our abdomen, the arch where the long axis is along the 10th rib. Just perform this Castelli's method, Nixon's method is very important. If you feel that, then go back, go back again, palpate the spleen, recheck your findings. If you're not able to appreciate, definitely you can tell your examiner, sir, I'm not able to appreciate splenomegaly. Here, don't use the term palpable spleen. We all know that if a spleen is palpable, definitely it is enlarged. So very important percussion method. Suppose if there is an obvious splenomegaly, you can see from the point of inspection, if you're able to see the fullness in the left upper quadrant, you can see something moving with the respiration, and you can palpate the tip of spleen near the umbilicus. You're feeling the notches of spleen, and there is no point in going ahead with the Castelli's method, Nixon's method, and all those things. Of course, you can check for trough space. Some examiner asks, have you checked the trough space? You can say yes. When there is a massive splenomegaly, you can confidently say yes, I have checked. Little obliterated, finish. But in when there is a massive splenomegaly, if there is clear-cut evidence of the spleen on palpation and all, there is no point in going ahead with Nixon method, Castle method, and all those things. We all know, the spleen has crossed the costal margin. Definitely, whatever the spaces we describe will be obliterated. So that's what. Because some people, just even you give a large spleen with some hematological malignancies, they'll just write these headings. They'll just write these headings and write Casel's method, Nixon's method, XYZ method, not required. Okay, if you're ready to appreciate, just go ahead. Next important, other than solid organ percussion, is to find out whether there is a fluid in the abdomen or not. Of course, we see, this is how I'm palpating. Sorry, I'm percussing here from the xiphisternum. I go first initially up to pubic symphysis, because this is very important. First percussion line should be from the xiphisternum to the pubic symphysis, because people may have fluid in the shape of horseshoe. Then definitely you'll appreciate the dullness. Of course, sometimes, if an enlarged bladder and all this there, you may not appreciate the abdomen bowel node. You may feel dull because of any other enlargements. But anyway, it is always preferred to percuss initially between the xiphisternum to the pubic symphysis. Initially, just this is just I'm showing how fluid accumulates in the abdomen. Bowel loops are always filled with gases. So whenever there is a bowel loops are filled with gases, we all know that they are attached to the mesentery and everything. So they are freely floating. They are freely floating. So once there is fluid in the abdomen, when the patient lying down in the supine position, bowel loops appear at the top. They take the top position there. So fluid accumulates on either side. So the flanks will be full of fluid in this case. Slowly, with excess fluid accumulation, as fluid accumulates, you get a horseshoe shaped dullness. Once there is still accumulation, the horseshoe proceeds upward, 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 and the whole abdomen becomes tense. If there is a large ascites, in my last class, I was asking that whenever there's a large ascites, tense ascites, the percussion itself is something. What you do is you check for fluid thrill. Fluid thrill means you ask attendant or somebody to do keep a hand like this. Most often you can ask patient to keep a place the hand like this. This maneuver is done to prevent the whatever the you to tickle the abdomen, you just give a knock the abdomen. Then in that case, you want to prevent the waves traveling from this end to that end via abdominal wall. You don't want waves to transmit through abdominal wall. That's why you place a hand to interfere and to interrupt it. We want the waves to get transmitted from this end to that end via fluid. It is through the fluid. That's why we place a hand here. See? Okay. In case of tense ascites, in case of large ascites, yes, you appreciate the thrill. You appreciate the thrill there. That is how, placing hands like this will prevent the waves from the abdominal wall. Then for shifting dullness, you move from this thing, then again come back laterally. Shift then you should not remove your finger. That is very, very important. The point of dullness shouldn't be changed. It is not that you keep percussing from the xiphisternum, you keep in a straight line, you keep coming down, then take a 90-degree turn, then come to the flanks, you feel dullness, you should not remove your finger. The point of dullness should be kept like that. I'm not removing my fingers there. The point of dullness, I know that that part was dull because of fluid. I waited for a few seconds, roughly 30 seconds. I wait for few seconds and then again check it, and again I'll percuss it, I'll check it. The dullness should obliterate. Okay, the dullness should obliterate. What does that mean? That means previously both the flanks were full. There was fluid in the right flank in this patient. I examined, I felt dullness. I turned the patient to the left side, waited for a few seconds. In that case, the bowel loops floated upwards. Whatever the fluid was there in the right flank just flows because there is a free fluid in the abdomen. It is not a loculated fluid. In case of loculated ascites, which you see in tuberculosis and other malignancies, you may not see this shifting dullness. If at all, if you're appreciating this shift of fluid from one end to other end, that indicates a free fluid in the abdomen. So, and sometimes there is another entity where once they lift this finger, they try to go to the other end. They try to go to the left flank just to check whether the dullness has increased. Of course, when there is a loss of dullness in the right end, definitely the left end will little increase. That doesn't add anything to your finding. So after shifting dullness, basically this is how I'm just explaining. See, let us assume that this is our body. Whenever there's a free fluid in the abdomen, let us say this is abdominal cavity. Whenever there's a free fluid in the abdomen, air is always at the top and fluid settles down, so that when you percuss in the upper abdomen, you may get a tympanic node or node due to the air in the bowel. But only in the flanks on either side, you feel the dullness. It is just like water bottle. You make the patient sit. In that case, the anterior part of abdomen, particularly below the umbilicus, which was showing a dullness of bowel may get obliterated. So this is how, this is a rare thing. Usually if people ask what happens when you make this patient sit, how does the shifting dullness vary? Only then you can show this, that when the patient sits, the upper abdomen, all the bowel starts floating, the upper abdomen becomes filled with air, and the lower abdomen, both anteriorly and in the flanks, will show a dull note. So it is just like water bottle. Patient has sit. Because previously some examiners used to make the patient sit where they used to percuss in the midline and check the, suppose if somebody asks you, how can you demonstrate shifting dullness in the midline? Definitely yes. Let the patient lie down, percuss the midline. Most often, whenever the fluid is just accumulated in the flanks, midline shows a dullness of a bowel. But when you make them sit, the lower part gets obliterated. So this is how you should look for puddle sign. Before examining puddle sign, make sure that the patient lies in a prone position. Patient lies in a prone position for roughly 2 to 3 minutes. So after patient is in prone position for 2 to 3 minutes, examining him, please explain him that you're going to do this procedure just to look for minimal ascites or minimal free fluid in the pelvis, in the peritoneum. You don't have to do all the tests. As I mentioned in my previous class, that when somebody has a tense ascites, you don't have to do all these things. When there is a tense ascites, there's no point in. Of course, when there's a horseshoe dullness, you may look for shifting just to make sure that it's not loculated and all those things. But when there's a clear-cut tense ascites, shining skin, where patient has some respiratory distress, fluid thrill is enough. Fluid thrill is definitely enough. Whenever you get horseshoe dullness, of course, you may do other maneuvers to look for whether it's a freely mobile or not. Puddle sign is done only to elicit the minimal free fluid. Clinically, puddle sign is rarely used. Clinically, it is rarely used. I mean, in a day-to-day practice, I see. But for examination, definitely you should know how to do and how to perform this. So patient was in prone position for roughly 2 to 3 minutes. This 2 to 3 minutes will make the bowel to float. When he's in prone position, bowel goes backwards and the fluid accumulates in the lower part. Just ask the patient to sit in knee elbow position. This is a ausculto percussion method. I keep my stet at the most dependent part. There are two entities. Some examiners say you should just give a flickle, or you can just scratch screen. If at all, if there is a free fluid, small amount of free fluid in the abdomen, the note should change. Puddle sign may be difficult to perform. If at all, if the patient is in distress, please do not go ahead with puddle sign. You can explain the examiners that patient is in distress, so it was difficult to perform puddle sign for me. Because once you mention, sir, I'm not able to appreciate any free fluid in the abdomen, the next question is they'll ask, what is the minimal fluid you see and how much you see and how do you do? You say puddle sign, then they'll ask, you to perform puddle sign? Then you can say, patient is in distress. Let us say patient is in hepatic encephalopathy. Abdomen case, ascites, has hepatic encephalopathy. Patient has some painful organomegaly. very tender liver, then patient is not comprehensive. He doesn't understand that he has to sit like this, knee, elbow, and all those things. Then you may just tell the examiner it was difficult to make appreciate the free fluid via puddle sign. Coming to the last part, that is auscultation. Auscultation has a role, particularly when it comes to bowel sounds. Other than that, the theoretical part, which we often discuss, let us say the hepatic rub involving the splenic rub, hepatic rub, hepatic artery bruit, venous humps. They are more of a theoretical entity, and it is very difficult to appreciate them clinically. We all know that hepatic bruit, hepatic artery bruit, you see that hepatic bruit, you see that in hepatocellular carcinoma. But when it comes to day-to-day clinical practice, less than 10% of all these tumors will show excessive flow, which is picked up by a stethoscope. But very important things we should not miss is bowel sounds. Bowel sounds are audible throughout the abdomen, but they are better appreciated in right lower quadrant. They are better appreciated in the right lower quadrant. You don't have to measure that is 1 centimeter below umbilicus, lateral to umbilicus, and all those things. They are better appreciated in the right lower quadrant, because there are a lot of theories. You have ileocecal valve, where there is a change in caliber from the small intestine to large intestine, where the food material is pushed into the colon. That's why it is better appreciated. So conventionally, we hear in the right lower quadrant. Bowel sounds, normal bowel sounds are gurgling sounds. They are gurgling sounds which we usually hear every, let us say, 2 to 5 seconds once. So at the end of 5 seconds, you may just use your step and auscultate your right lower quadrant. You'll appreciate it. Roughly every 2 to 5 seconds once you hear a gurgling sound. If you hear enough sound for 30 seconds, then you can just say bowel sounds are normal. Of course, in the initial part of obstruction, there may be exaggerated tinkling, borborygmy, and excess bowel sounds. But normally, if you see enough bowel sounds at the end of 30-second examination, that is enough. But when you want to commit that there is absence of bowel sounds, or you want to say there are no bowel sounds, or bowel sounds are very sluggish, it is preferable that you see for at least 2 to 3 minutes. A minimum of 2 to 3 minutes examination, minimum of 3 minutes according to many examiners. Minimum of 3 minutes complete auscultation to say that there are no bowel sounds or sluggish bowel sounds. So after auscultation, another entity which you want to see clinically is something, all this bruit, not on the organs. If at all, if theoretically, if they ask, where do you look for renal artery bruit, where do you look for other arteries? See, this is somewhere between midpoint, between the xiphisternum and umbilicus. Go roughly 2.5 inches lateral to it. Place your step there and look for renal artery bruit. Similarly, just below the umbilicus, 2.5 inches below and lateral, you hear iliac artery bruit. Whenever there is an obstruction. So this is how clinically you should go ahead with auscultation. So rest of the things are the theoretical part which you should know. Hello, Kishan, are you here? Hello. I think
Yes,
this
sir.
is. Hello.
Yes, sir. So Shravan here.
Yeah. Hi, Shravan. Hi, Shravan. I'm
Yes.
done with my video.
Yes, sir.
Any questions or anything from the viewers, any students or anybody? I'm ready to answer.
Sir, if there are any questions in the chat box, I'll just keep reading them out.
Just okay,
Yes,
okay,
sir.
yeah, okay. Urinary bladder when full, definitely. Uh, I think Dr. Vishruth has asked. Full urinary bladder, we all know that it interferes with your examination. Clinical, when you want to perform clinical examination, it is always preferred that your patients will void before examination. It's always. Otherwise, particularly when you want to come in, when you come to percussion, when you want to percuss between the umbilicus and the pubic symphysis, urinary bladder interferes. Full bladder is not a good entity for palpation or percussion. It causes a lot of discomfort. Of course, full bladder is always essential in case of the obstetrics and gynecology and radiology, where they want to do some ultrasound and all those things. But clinical abdominal examination, full bladder is not preferred. It's very difficult, when somebody with a full bladder, you start palpating, you start percussing a lot, it's very disturbing. So full bladder is not preferred usually. Should Next question: should Nixon's method be done in supine or light right lateral position? It is done in right lateral position. Right lateral position. It's not in the supine. Preferably right lateral position, because you draw a diagonal line in Nixon's method. It's yeah, I showed the lower costal margins. From the midpoint, draw a perpendicular line and move diagonally. When you're moving diagonally, you tend to go back. So instead of patient just lying in the supine position and you go to his axilla, go back, it will be discomfort. So preferably you can make him to lie on a right lateral position and go ahead, so that you can easily percuss and you can also appreciate the distance of dullness. Then, how jumping helps in palpation of spleen? Yeah, see, previously this jumping method was used for both liver and as well as spleen palpation. But frankly speaking, there were a lot of theories in the older fancy textbook that jumping few times will just make the ligaments lax and you can better appreciate. Both liver and spleen, jumping few times will make the ligaments lax. They don't tear the ligaments, make the ligaments lax so that you can appreciate. But definitely it is nowhere clinically practiced, and it is a theoretical one. They may ask question, you may just answer that it makes the ligaments lax and we can appreciate better. But clinically nowhere it is done, and it is not supposed to be done. How to measure the left lobe of liver span? This is a very important question. I actually skipped while telling these things. Left lobe enlargement is very important. We all know that left lobe crosses the midline in the xiphis sternum, and sometimes up to 3 centimeters you can see. In a palpation and percussion wise, if you want to demonstrate the left lobe enlargement through percussion, please start percussing along the midline sternum, unless there is a large mediastinal node or any solid mass, you don't appreciate dullness in that area, or a cardiomegaly or anything. Let us say patient doesn't have anything, then you start percussing in the midline. The left lobe usually is not more than 3 centimeter in the vertical height. Suppose if it is exceeding more than 3 centimeter, then definitely we can say that the left lobe is enlarged. While palpating, just like we palpate the normal liver, usually you go ahead and palpate the epigastric area to appreciate the liver enlargement. Here you can see something which is in continuous. Whenever the liver is enlarged, just move along the border, press it on the epigastric region, you feel liver enlarged. It moves with respiration and everything. Why it is important? Definitely. The next question would be, once you say, sir, the left lobe is palpable, left lobe is little extended, it's more than 3 centimeter. Next question is, what is the significance? We all know that there'll be volume redistribution of the liver in the cirrhotic phase. The left lobe is preferentially enlarged, the caudate lobe is preferentially enlarged, the right lobe undergoes atrophy. There is volume redistribution. So that's why left lobe becomes important. Next is how to identify shrunken liver, sir. Shrunken liver, definitely, there are two entities here. Shrunken liver without ascites, definitely measure the span. Let us say if the span is 6 centimeter, if the span is 5.5 centimeter, definitely the liver is shrunken. If you're not able to feel, but only the percussion dullness you are measuring, it is, let us say 5 centimeter, 6 centimeter, definitely it is shrunken. But in clinical settings, we all know that shrunken liver, the moment they come to you for this palpation, percussion, definitely ascites will be there. So in that case, you have to palpate. If you're not able to palpate, then it is definitely difficult to appreciate. Let us say you have a patient with a liver span of 5 centimeter, 6 centimeter, completely shrunken liver, has mild to moderate ascites. Abdomen is full of fluid, and we all know that because of diaphragmatic entry, right effusion is also common. Patient has moderate right pleural effusion. So moderate right pleural effusion, moderate to massive ascites with a shrunken liver. You may miss it. Definitely, you can't identify it. In that case, you can tell, sir, I'm not able to make the borders. I'm not able to make the liver because of massive ascites and right pleural effusion. Please once again tell the methods of liver palpation. There are four methods. One is a conventional method where you place your left hand on the shoulder, just start palpating from the right iliac fossa. Place your hands parallel to the organ margin. Slowly, you should go in the cranial direction. Every 2 centimeters with one complete respiratory cycles, you go up. That is the conventional method of liver palpation. The second method I told you, where you place your fingers parallel to each other towards the patient head vertically, then slowly go ahead just to appreciate the margin or borders of the liver. That is an alternative method. Another method is a bimanual method, which is often performed in a hefty individual, a muscular individual, or an obese individual, where you place the hand just below the 12th rib margin, push it upwards, and appreciate the liver. The fourth method is a hooking method, where you just go behind the patient, or in the even if the right sided itself, standing on the right side itself, you hook your fingers and appreciate the margin and borders. Hooking method will not, you may not appreciate the surface, consistency, and all those things. However, margins and borders are well appreciated. Sir, can you tell the amount of fluid science in positive and ascites? I didn't go into this, preferably because all your clinical method are different. They say some site is up to 500 ml, 500 to 1000 ml in this, less than 300 ml can be seen in puddle sign and all those things. But I went through a lot of other gastroenterology books also. 300 ml and less than 300 ml given in your clinical books, it is, may not appreciate. 300 ml is nowhere appreciated. 300 ml fluid in the abdomen is difficult to appreciate clinically, and nobody ever mentions the threshold for puddle sign and all. I would suggest you can follow any book. Of course, 1 to 1.5 liter for fluid thrill, that is definitely okay. Is there any clinical method for liver span in patients with massive ascites and effusion? That's what I told. No, clinically it is very difficult to go ahead with the span. You all get wrong values. Better to go with imaging. Is palpation of a cirrhotic liver possible? Yes, we all know that cirrhosis means, you should remember this, cirrhosis means liver can be normal, liver can be enlarged, and liver can be shrunken. A perfectly normal 12 centimeter liver, let us say, I do fibroscan and I found out that patient is in early cirrhosis, or the fibrosis scan shows high values, definitely. So cirrhosis can have normal liver, one. Cirrhosis can have a large liver. If you go through the last previous clinical discussion, I was telling my colleague who was presenting the case, one of your friend, I told him that even a diabetes and cirrhosis, you may have a huge liver. storage disorders and cirrhosis, you may have a huge liver. So in that case, there is hepatomegaly. That doesn't mean that there is no cirrhosis. You see it under a microscope, you may have fibrosis again. So it is nowhere related. Shrunken liver can also be palpated. There, what happens when there is a preferential left lobe enlargement? I told you, whenever cirrhosis occurs, left lobe enlarges, caudate lobe enlarges, right lobe atrophies. So you can just palpate the left lobe. If you are appreciating the left lobe only and you are not appreciating the right lobe, still you can say, sir, the left lobe is enlarged. Could you explain when to avoid doing puddle sign? Could you explain when to avoid doing puddle sign? That's what I told. See, most of your patients which are given for examination, particularly abdomen, will have ascites. Definitely will have what I can say. I'll tell you how puddle sign works. Particularly in your exam, you will have moderate to massive ascites. Mild ascites is very less likely that you get such cases. But in those cases, you'll have organ enlargement and all those things. There, doing puddle sign is very easy. Let us say you get a case of splenomegaly. You want to check for ascites, you do puddle sign because you want to rule out even a minimal amount of fluid. You can do it. But let us say you have a patient of moderate ascites, jaundice, distended abdomen. There is no point in doing puddle sign. If your patient already has a grade 1, grade 2 HE, there's no point in doing puddle sign. If your patient is difficult, he doesn't understand your instruction. You ask him to lie down in a prone position, he doesn't do. Knee elbow, it is difficult to do. Don't do puddle sign. Your patient has a painful organomegaly, painful liver, is already screaming in pain. Your friends have examined, you are poking liver. Don't do puddle sign. It's not indicated. Can we make the next question? Can we make the patient lie in left lateral position who has ascites and percuss the mid axillary line to know the liver span? Yeah, this is also one of the entities which they do. Mid axillary line is usually percussed to know the liver span, but it's a difficult this thing, and usually it is clinically not done. Of course, it's I can say theoretically yes. Let us say patient has ascites, you put him in left lateral position, fluid moves, and you can percuss the thing. But in a case of shifting fluid like that, you should also appreciate that when you percuss, when you normally percuss for a liver span, we percuss mid axillary line. So suppose if the patient has a shifting dullness, mid axillary line is usually a mid axillary line, it doesn't get dull unless there is a large ascites. Unless there is a large ascites. But when in that case of large ascites, sometimes they'll have moderate effusion. You can try this method. You can just theoretically tell this you want to shift the fluid and go ahead. I know there are a lot of my examiners also were telling, can you put it on right lateral position and do and all those things. Theoretically yes, but practically difficult. You can just sit and think, somebody has a moderate ascites, definitely the mid axillary line may not be dull because the fluid shift. If there is a fluid enough to obliterate the mid axillary line, you just imagine if the fluid is obliterating the mid axillary line, then definitely it is difficult to shift and all those things. And because they have pleural effusion also, they'll have moderate pleural effusion. Then pancreas palpation, if enlarged, how to do? Okay, let me tell you, pancreas, very important entity. Pancreas is a retroperitoneal organ. We all know all retroperitoneal organs cannot be palpated unless they are massively enlarged. Anything, whether it is kidney, whether it is pancreas or anything. Let us say you have a small 1.5 to 2 centimeter mass in the upper pole of kidney. You can never palpate it. Small 2 to 3 centimeter mass in the lower pole of kidney. You can never palpate. Similarly, pancreas, unless it enlarges to that extent where you are clinically palpable, it is very less likely. Whatever pancreatic masses you palpate, you clinically, it's more of a pseudocyst or a peripancreatic collection. The pancreatic mass reaching to that extent, Patients will have jaundice, they'll have gastric outlet obstruction and everything. Let us assume that you got a huge pancreatic mass. You should look for other signs. Definitely, I can bet you 100% they'll have, because the commonly all pancreatic masses arise from the head. When it comes to malignancy, it is the head region. They'll cause jaundice. They'll cause gastric outlet obstruction. You can feel a swelling in the epigastric region, which barely moves with respiration, which is fixed. We all know when do you expect a swelling to be fixed? Either it is deeply infiltrating, so it is fixed, or it is retroperitoneal, it is fixed, or there is chronic inflammation, it becomes fixed. So large pancreatic mass will definitely have all these features of jaundice and everything. It is palpable in the epigastric region and rarely moves with respiration, because mass arising from the left lobe of river definitely moves with respiration. Mass arising from the stomach definitely moves with respiration. So, okay, what is the next question? What is the normal shape of abdomen? Okay, normal shape of abdomen is nothing. You can say abdomen is normal in shape. You don't have to describe it unless it is scaphoid or anything. How to know if Riedel's lobe is enlarged liver is versus enlarged liver? This is very, very important. This is very important. Here, see, we all know Riedel's lobe is a tongue-like projection extending downwards from the liver, which is often mistaken for a gallbladder. Only the tip is palpable, then you may think it is gallbladder, because even the gallbladder also will be in the same region, between the rib and the lateral part of rectus abdominis muscle. In this case, you have to palpate liver both in the mid axillary line, in the mid clavicular line, then in the mid axillary line. Palpate for the left lobe of liver. If at all, if the palpable mass is movable or not, please check, differentiate it from gallbladder. How to do palpation of kidney? We all know that kidney is a retroperitoneal organ. Unless it is massively enlarged, secondary to some polycystic kidney disease and all, it is difficult to palpate. If you are palpating kidney, it's most often, huge. You might have seen in pediatric wards, no, polycystic kidneys. We do it in. You should remember like this: 3 B's. How I remember kidney is 3 B's. One is palatability. Okay. Second is bimanual palpable. Third is band of colonic resonance anteriorly. 3 B's. The first is palatability. You know that just like the bimanual palpation of liver, you should place the left hand between the below the 12th margin, lateral to the erectus pene muscle, then anteriorly. Just you have to push that up. Just give a push. Whether if it is enlarged renal mass due to all these cysts and all, it will come and touch you. If you even with that is palatability. If you can palpate on the either end by pushing your lower hand, appreciating the enlarged mass in the upper hand, that is bimanually palpable. So bimanual palpability, palatability, and band of colonic resonance. What is that band of colonic resonance? Because kidney is an retroperitoneal organ, whenever kidney enlarges, it pushes the intestines further anteriorly. It pushes it up. So all these bowel loops will be pushed anteriorly. So despite having mass, you get the band of colonic resonance there. So 3 B's. That is how you appreciate kidney. Palatable mass is something that's what it is freely moving. It is surrounded by that fat and fascia. There's little scope for that movement. So that's why it is freely moving. Sir, should we generally elicit palatable kidney in an abdominal case? I told you, palatable kidneys are, when do you get palatable kidneys is when they are massively enlarged. Kidney is a retroperitoneal organ. Particularly in a large cystic diseases of kidney, you feel that palatability. Otherwise, it's all theory. When you say, sir, there is gallbladder palpable, then they'll tell, how do you differentiate between gallbladder and kidney? Then you are supposed to tell all these points. That gallbladder is a superficial, it is intraperitoneal, kidney is a retroperitoneal. Gallbladder shows mobility side to side. When in case of other thing, it is difficult to show side to side mobility. And they'll ask you on the left side, if you are palpating spleen and you tell, sir, this is splenomegaly, they'll ask you how to differentiate between a splenomegaly and kidney enlargement. Okay, but you don't have to make any mention that there is no palatable kidney. No. Whenever there is an enlarged mass, then you have to go ahead. How to differentiate between the direction of flow in portal obstruction and IVT obstruction? Please tell, sir. Okay. See, you should know this. What happens in portal obstruction? Last time when we were discussing abdominal case, I told you the normal flow is the same thing. You know, the umbilicus as a watershed area. Veins above the umbilicus go upwards, veins below the umbilicus go downwards. This is the direction of normal flow. In the portal hypertension, there is no change in the direction of flow. You should remember this. All your chronic disease, chronic liver disease patients, cirrhotic patients, they will not be change in the direction of flow. Okay, you see a chronic liver disease patient with portal hypertension and engorged veins in the anterior abdominal wall, the direction of flow remains the same, but the flow is augmented. You know, the veins become enlarged, more prominent, but the direction remains same in portal hypertension. Whereas in IVC obstruction, I told you, in case of abdomen, particularly in case of that Butt-Chiari syndrome and hepatic venous outflow tract obstruction, there will be veins on the flanks, veins on the flanks, veins on the back. Okay, then you have to empty them and see how it goes and all those things. But you should always look for veins on the flanks and back to differentiate between portal hypertension and this thing. Once there is only portal hypertension, then there is no fun in telling the direction of flow. Definitely it's the same direction, but it augments. Any other questions? Hello.
So I think that's all questions, sir. Both in chat box and even on YouTube, there are no more questions.
Okay.
Uh,
Okay.
yes, sir. So thank you so much, sir. That was a very, very comprehensive session. It was, sir, very beautifully explained for us. All of us students are very thankful for such a session. There has been constant demand for clinical examination sessions, especially for basics. Thank you so much, sir. It was a very, very comprehensive and very nice session, sir.
Thank you all, the White Army team, and as well as students. I can say I remember a lot of students, you know, last time also they kept on asking questions. Really, I appreciate their efforts. Actually, I want to apologize because my class was scheduled at 6 p.m. to 7:30 p.m. You know, in a private setting, I was stuck with a case and I had to come late. I had prepared a separate video for this. You know, one of our DNB residents had prepared a video that I wanted to upload it. Anyway, because of technical issues, I think I was able to reach everyone. You know, I
So,
just
so
muted the
that
audio
is
and I was able to.
not at all an issue, sir. In the current scenario, for us to get such a good session and for us all be able to attend a live session like this itself is very lucky for most of us. So
Thank you all.
thank you
Thank
so
you.
much, sir, for taking your time and recording a video and then coming and explaining to us in live, sir. It has been very, very helpful. Thank you so much, sir.
Thank you. Thank you very much. Thank you all. Please go ahead and read. That's what I would like to say. Read more books. Only then you will understand how to interpret things and whether they're clinically relevant or not. You know, I remember, you know, a lot of times in our UG days, we used to scratch our head why this is 300 ml, in some book it is 400 ml, some book it is 420 ml. And finally, we realized that it's not at all clinically important. And what is clinically important, everybody should know. Okay, that's very important. See, I described puddle sign and all. We know clinically we don't do it, but you should know it. As a doctor, you should know it, but you should also know the clinical importance of it. Like in the respiratory cases, we used to learn 25 signs, 30 signs of pleural effusion. but all of us know how we are practicing and what important signs we should remember. Anyway, I thank all the students here. I appreciate your participation, particularly the White Army team. Your efforts are really appreciated. Thank you
Thank
for giving me this opportunity to keep this teaching habit alive. Otherwise, we get just once you become consultants and you're busy with your practice, you forget everything. So
Sir,
thank you, White Army.
sir, we
Thank you,
need to
White
be
Army, for
thankful.
keeping me in the
Sir, we
stream.
need to be thankful that you're coming and taking such sessions for
Sure,
us
sure,
in a
sure.
busy
I'll
schedule.
take more classes and everything. Sure.
Thank you so much, sir. Thank you, sir.
Thank you, everyone. Take care. Good night.